Welcome, everyone. Thank you so much for joining us at Cope Health Solutions for our webinar today. I want to start by thanking the Bronx County Medical Society for their partnership in helping to host this webinar today. We're going to be talking about COVID-19 funding sources and some strategic considerations for independent physicians and physician groups. Very happy to have you with us. So Keith, we'll ask you to advance. Let's start with introductions. We've got a great team with us today. I'm Alan Miller with Cope Health Solutions. We've also got Dr. Andy Snyder. Dr. Snyder is our Chief Medical Officer and has a really strong background on the East and West Coasts, working with independent physicians as well as large academic medical centers, community IPAs with independent doctor run, as well as IPAs and clinically integrated networks connected with academic medical centers. And he's also done a lot of work on the data analytics and MSO side. So we're very, very pleased to have Dr. Snyder with us. And then we've got Sam Shutman, who's a Senior Vice President in the firm. And Sam has extensive experience with health plans, health systems, but again, a lot of experience in New York in particular, but also on the West Coast, working with physicians through independent physician associations, through health system physician organizations. So we're really pleased also to have Sam joining us today. Go to the next slide, please. A little bit of housekeeping. As we're going through the webinar, please feel free anytime to enter a question through the Q&A feature. You can also email us, info@copehealthsolutions.com. Toward the end of the webinar, if we have a little bit of time, we'll look at some of the questions and we'll answer some of the questions live with our speakers. Whether or not we get to all the questions or any of the questions, we will create a question and answer document, and we will send that out to all of you, along with a PDF of the actual PowerPoint and a link to this recording. So just want you all to know that. There's a brief survey at the end, and if you can complete that for us, we'd really appreciate it. Next slide, please. So our agenda today, we're going to walk through some of the short-term strategies, and I know something that's on the forefront of folks' mind with physicians being right out there in the field and really double challenged, having to take care of people and at the same time having had to shut down so much of the critical services that physicians tend to work through in terms of face-to-face, having to transform your practice to telemedicine. We understand there have been massive challenges, and so getting access to funding to support physicians is a key priority for us and for this presentation. And then at the same time, COVID is going to not close society permanently, right? Some of the COVID impacts will continue. Some will begin to fade away. What do you do on the go forward? How do you leverage what happened here to build a strong foundation for the future? And we wanted to look at it from very specifically a physician perspective, because there's been so much done, including by us, talking about health systems and health plans and others, but independent physicians, physician-run IPAs and medical groups obviously have a lot to gain if they can build the right foundation moving into the future, as folks need physicians in different ways. We'll have a brief summary, and again, if we have time, we'll go through Q&A. Next, please. So again, we know there's been a significant financial impact, and we have seen that independent physicians in particular have been hit hard. When we look at how the funding has flowed, so much funding has been formulaic. And really, if you have a Medicare cost report, meaning you're a hospital, you get money automatically. FQHCs have gotten money automatically. Independent physicians have had to fight their own way through it. And we don't mean just individual doctors, but small groups or large groups, IPAs, physician-run MSOs. This is a webinar to really help you think through how to get your money and understand what's the way to make that happen. There is money available. But they didn't just flow it through the doctors the way they did with the hospitals. And again, there's a need to be strategic. Certainly get the money as quickly as possible. We'll talk to you also about some of the issues around being ready for audits later, and make sure you don't take money you shouldn't take. Make sure your considerations and assumptions on why you should get the money are really solid. At the same time, what are you going to do with that money other than, of course, be able to reopen, keep your employees there or bring your employees back? But how do you want to be practicing medicine going forward? What's your place going to look like within your community? What are some of the opportunities? And so Andy's going to talk about that as well. So that's this presentation today, immediate funding and strategic considerations, and we're really excited to have this conversation with you. And with that, I'm going to hand it over to Sam.
Thank you, Alan. So first of all, I wanted to thank all of you for joining us today on this webinar. My piece, of course, as Alan mentioned, is to talk about the short-term considerations and make you more aware of the information that we've gathered on all of the programs and funding opportunities from the federal government, including the loan programs and the grants. When the COVID-19 crisis first started, we quickly realized that most hospitals and FQHCs are well supported and informed about federal relief by their own advocacy organizations. For example, in New York, you have the Greater New York Hospital Association who are backing and supporting the hospitals. You have Chicanis and the National Association of Community Health Centers that support the FQHCs. You know, in talking to Ronald Blount, the executive director of the Bronx County Medical Society, we realized together, Ron and I, that the independent physicians, the multi-specialty groups, which are known in New York as Article 28s, as well as the independent ambulatory surgical centers, even some of the smaller urgent care groups are most in need of our help and support. So while you, the physician, have focused on meeting the needs of your patients, delivering heroic medical services in the midst of this unprecedented pandemic, we've been busy researching the myriad programs that are available. If you could, Keith, go to slide 7, we can see a little bit more detail about these federal programs. This is sort of a high-level slide that gives you insight into the funding amount, whether it's a grant or a loan program, and a little bit about the eligibility components for these different programs. These are the programs, the ones in green are available now that you can access through the CARES Act and follow-up COVID relief funding. There's also a FEMA grant for not-for-profits for telehealth that is probably not likely to apply to you, but unless you're not-for-profit. So this gives us sort of an outline of what we're going to focus on today. These are the programs that we think are of most interest to physicians, medical group clinics, ambulatory surgical centers. Keith, if you could go to the next slide, we can hone in a little bit more here on what we think are probably the most applicable programs for you, the independent physician, ambulatory surgical center, et cetera, the groups that we've talked about. The $100 billion allocated to healthcare providers in the CARES Act, which has a few programs we'll talk about after this. We're also going to talk a little bit about the Main Street Lending Program through the Federal Reserve. This is separate and apart from the SBA PPP loans, which were obviously very problematic for many people. We're going to talk about that, and we're also going to talk about additional funds that Congress allocated to healthcare providers in the latest COVID-19 relief package just recently signed into law last week. So I guess we can go on to slide 9, please. So this slide, again, we're getting into a little bit more detail. As you can see on the left side of the slide, there was $30 billion that was allocated more in an automated manner set up for based on your Medicare fee-for-service reimbursements in 2019. So when I say Medicare fee-for-service, I mean the straight Medicare patient that doesn't have Medicare Advantage. So those monies were distributed, but unfortunately didn't really help a large set of providers, perhaps like yourselves, that have a lot of Medicaid or focus on children, such as pediatricians. Even children's hospitals didn't really do all that well. So to rectify that, the federal government allocated an additional $20 billion, that's in the lower left, so that providers that do not submit CMS cost reports, the independent practices that we're talking about today have a chance to get the funding that they need. So in addition to that, Congress also and the administration also allocated money for the uninsured. So I think we can go ahead and move on to the next slide, please. So the basic eligibility is that you have to have a Medicare provider ID number, it's likely, I guess it's important to say that it's likely that if your payer mix is primarily Medicaid, you're most likely going to get a lot more money than you did on the first go around, because that was just focused on Medicare fee-for-service. I'm probably going to jump ahead to your Q&A, but everybody wants to know how much money they're going to get. And I have to say that that's more or less an unknowable number right at the current moment. We do know, however, that if you have a large Medicaid payer mix, it will most likely be more than you got in the previous distribution of the $30 billion. And there'll be some relationship between your 2019 revenue and how much money is in the total pool in terms of the $20 billion. I guess folks that are trying to tell you that they know exactly how much are probably not being 100% transparent. But the good news is that these programs are not going to disappear overnight, as would happen with the PPP loan program. The federal government is doing these grant programs not on a first-come, first-served basis. You can see on the right side of the screen. There's going to be rolling applications, rolling approvals, and once you apply, we're confident that you should be getting payment within 14 days. In terms of what you need to apply, in that middle column in number 2, it's pretty simple, pretty straightforward. You need your most recent annual tax return, an estimate of your revenue loss in accordance with the guidelines, and your tax ID. Keith, I guess we can move ahead to the next slide. Okay, so this slide we're going to talk about monies that have been made newly available to provide you with reimbursement when you're treating uninsured people, right? So obviously, these are people that are not members of a managed care organization, right? They're uninsured, they have no insurance. So the federal government is providing for reimbursement. Again, this will be a claims submission on the portal. As you can see on the right side of the screen, you can start submitting your claims on May 6th. And if you've been doing testing, in other words, you suspect that somebody has COVID-19, you don't know for sure, but you suspect that they may, and you provided the swabs and the testing and so on, you can submit those claims. And you can also submit claims if the primary diagnosis is COVID-19. So many independent physicians, they run their own practices in their own offices, but occasionally some of them also round at hospitals or are involved, have been involved on the front lines, helping in treating patients in the hospital setting. Obviously, if you've done that kind of work as an independent physician under your own tax ID, when you're rounding in hospitals on COVID patients, you'll be able to submit those claims as well. This is for dates of service, as you can see in the middle of the screen, on or after February 4th. If you have any further questions about uninsured, you can post those questions on the Q&A, and we can talk about it later or at another time. You can go to the next slide, please. Okay, so this slide's about the Main Street Lending Program. I think the important thing to know here is that this is not the PPP program. It's a separate program, which you can also access. And these funds are being provided by the Federal Reserve Board. So it's a separate a separate program. They are 4-year loans at a very favorable interest rate, which is going to be very close to 3%. I think, the good thing about this is, it can help you stabilize what you have and also plan for the future, which I guess, is apropos to what Dr. Snyder is going to talk about, because he's focusing his information on this webinar for future considerations, future strategic considerations, and to the extent that you're in need of capital, to expand and grow your practices. I think this is a program, the Main Street Lending Program, that you may want to consider, and obviously we're here to help you with that if you need our help. Keith, you can go to the next slide, please. So this slide is just to let you know that there's new programs coming around. As you know, there's been several iterations, several different funding opportunities for grants and loans, even in the last few weeks. This is the latest legislation from April 24th, which allocated an additional $75 billion for providers in relief funding. This one hasn't been turned on yet, but it will be turned on. So, the message here is that, we're going to, at Copel Solutions, we're going to keep you informed about all these new funding opportunities as they arise. We know that as physicians running practices and trying to deal with all the stress of the last few weeks, you may not have the time to do that kind of research. So we're on top of this. This is one example of a new program that's going to be coming online. Next slide, please. So, this is a federal program. So obviously, whenever you have a federal program, you have to be cognizant that there are compliance issues. It's very important to be aware of them. At Copel Solutions, we have a 20-year spotless track record of supporting our clients through many federal and state programs, filing numerous reports and documents. We've never had an issue. We pride ourselves on our ability to understand the regulations and help keep our clients, all of our clients, in compliance. So I guess some of the tips for you is that it's important to track all the funds that you received, to make sure that no expense is paid for twice by the same source of funds, that you document your revenue lost, your additional expenses. In particular, there is a requirement that if you receive more than $150,000 from the Provider Relief Fund, that you'll need to submit a quarterly report to HHS indicating how those funds are being used. We don't think that's a particularly onerous requirement, but it's something that you have to be aware of so you stay in compliance. Another important one, which is already applicable in New York State and other places where you're not allowed to balance bill folks that have Medicaid or Medicaid managed care. This is called out in this new law in particular. So, for example, if a patient comes to you, they're out of network with the plan, that you don't have a contract, let's say, with one of the managed care plans. That person comes in, your normal charge for a visit, let's say it's $500. Whatever you're reimbursed is kind of what you have to take. You're not allowed to balance bill that number, the money to close that gap. And I think in New York and California, other states, I think providers mainly already know that, but just wanted to call that out. And it's also important to realize that the rules might change. And it's important to stay on top of these compliance issues. And again, as things change, we'll be, keeping you in the loop, and so on. So I think that's about it on this slide. And at this point, I'd like to hand it off to Andy Snyder, our Chief Medical Officer.
Great, thank you, Sam. And Thank you, everyone, for joining. Good afternoon. The acuteness of this COVID-19 crisis will seemingly have a long-lasting impact on the practice of medicine. Physicians and groups, both big and small, that I speak with around the country now, were somewhat caught with our pants down, right? We were left exposed. In a fee-for-service world, suddenly, when patients can't come to see you, business goes to zero. Most physicians and groups are lacking the infrastructure to shift that care model abruptly or acutely enough. So, going forward, to set the stage, physicians just cannot be again that vulnerable, and patients cannot again lose almost complete access to their care. So we've got to do better going forward. So let's next slide, please. So at this crisis, other immediate changes took place swiftly as well in the regulatory environment. So blanket Stark waivers were put in place, and this now allows systems, hospitals and systems, to invest immediately into community practices for access to care related to COVID, but access to care, almost anything related to COVID. So they could be supporting telehealth infrastructure, care management services, other wraparound services, behavioral health, and others. At the same time, there was relaxation at the FTC and the DOJ on the anti-competitive rules to promote wider community collaborations. What they want are these systems and hospitals to now work with the community hospitals, work with community assets out there, the CBOs, and other organizations much deeper. This crisis caught a lot of people off guard, and all electives were shut down. Some places could be open for electives, some could be pre-designated for crisis work. Things have to be thought of differently going forward in a probably more flexible fashion. But one thing we can be pretty sure of is that under new investment rules, that leads to consolidation of the markets. And that's what's going to be happening right now under our feet. So insurers will also get into the game. In fact, just this week, Blue Shield of California announced that they purchased Brown & Tolan Physicians, a 2,700 IPA, the largest IPA in the San Francisco Bay Area. There's no bad decision. That's not a bad thing. It's not a bad alignment. Physicians don't have to realize where they are, though, in the food chain, so to speak. And what would concern me about that is that it may seriously limit physicians from moving upstream on the premium dollar, which is where physicians need to go to be more sustainable and be able to grow in the future. Next slide, please. So clinical integration now can allow for this local and regional collaboration. We've heard about it, CINs, we've heard about clinically integrated networks at the physician level, but they can also occur at the institutional level, allowing for investments in services that support access and information exchange across previously competitive entities of any size. Single practices, we're talking up to hospital systems. So systems can affiliate with community hospitals without acquisition. They can provide resources in ways that were never possible before, at least temporarily and for now. But it's for the longer term strategy of wider network collaboration across geographies. So when crises like these occur, we're not caught again trying to figure out how and where to see a patient. But another thing the COVID crisis has taught us is that we need, obviously, as I said, flexibility in the facilities and the sites of services. We can't scramble like we're doing now. So a plan B, it needs to be ready to go to be able to continue a care model with your patients and to continue revenues at the practice level. And at the same time, we have to keep in mind that the next crisis won't be the same crisis. The next pandemic might be a different virulence, a different transmission rate. It could be a financial crisis. It could be an environmental crisis. We have found that if you put us in the business terms, the supply chain of healthcare delivery was just broken. And we have to be very cautious that that really can't happen again at the practice level. COVID affected everybody, but all those chronic diseases haven't gone away and they haven't gotten any better. So next slide, please. And we'll talk about some of the things you can think about now and going forward of where you need to be as a physician in the community and where you want to be. So immediately, obviously, we talked about the funding sources that were discussed. That's to sort of maintain payroll, staffing, office infrastructure, that you got to keep the lights on. And that's the first, obviously, priority for everyone. But you can also now approach the health systems and your systems for investment, according to those Stark waivers, for IT infrastructure, communication platforms. You can go to the payers for advances on pay. We can be creative now, and sort of the guardrails were taken off in order to do so. So short-term, strategically, we have to think about that, because not everyone is just needing to keep the lights on. There are some really strong groups out there, IPAs, CINs, and well-funded groups as well. So if consolidation is going to happen, why not it be physicians? So you can aggregate, you can join IPAs, you can join CINs in the communities. I know in the Bronx community, you have all the above. You have community hospitals, you have large systems. You've got CINs, IPAs, and private practices unaffiliated. You have all varieties at play, and new ones can be formed or merged. So with new monies, there is new capital coming in. But obviously, how and who you join depends on how you're governed, maybe how you're paid. So these choices have ramifications long term. But again, consolidation is happening, and the reins have been taken off for now, at least temporarily. So you can't be left behind, and you have to sort of figure out your path. Long term, well, actually, let me finish up on the ASCs and virtual services. We talked about flexible spaces being planned, but this could be planned ahead and contracted ahead. If you have a physician-owned ASC, what is your staff and your space good for in an alternative setting? Can you be a testing center? Can you be a triage center? Maybe you can be doing the electives. Maybe you are one that holds the COVID or the next COVID patients. You could be a command center, communication center, a community resource center, food center, telehealth center. There are options for facilities that we just are scrambling to do now that could be pre-wired to go forward next time with revenues attached. Long-term changes are and will need to change to the care model, right? If that supply chain was broken, we needed some aspects of a new care model to plug those holes. That some of it is IT and platforms, some of it is flexibility of sites and the flexibility of doing work differently. Now that they've allowed telehealth visits to be the same fee rate as regular visits, at least temporarily, the models are moving. So if you don't have the infrastructure, this is a good time to start partnering with someone to get it. The other thing to think about long-term is partnering differently across your communities. So not just from hospitals and systems, but even at the private practice level, you need to start thinking about relationships with your FQHCs, your REHCs, your CHCs, and the CBOs in the area, the community business organizations. What's happened in this crisis is a wealth of patients have just become unemployed and many uninsured. And that, again, unfortunately, probably won't turn around on a dime. So you'll be sharing patients with organizations like these that you may not have even shared with before, or at least at a scale you haven't shared with before. So communication pathways have to be opened up and solidified. So there's lots of work that can be done while there's been large shifts of patients under coverage. Next slide, please. So what is best for you, right? How do you know what approach to take? It's complicated. Your local environment matters, and the experience as to what the possibilities are matter. So it's hard to go at it alone. But how consolidated is your physician market? If you're in a market that has one IPA, well, there's your choice. If you've got many, start doing some research. How organized? How are their physicians organized? How's their governance? How happy are they? Do you want to be employed or acquired? One note on that is that there's, again, no bad choices. Everyone has a personal path. The my concern about employment is that systems and hospitals, A, just won't be able to do it fast enough, or B, aren't interested necessarily in new real estate and other assets. So it's a trickier deal these days if you own your practice. But how many systems are in the market that you're competing with or might come after you? Are you in a monopoly environment? It changes the calculus. And how much capital do you have? Maybe you become the aggregator, right? And all these choices and who you join has a trade-off of autonomy for administrative duties. And that's a very simplified version of what gets traded off here, but it's your practice at this point, and you want to be able to steer it going forward. Next slide. So there are things that are in the community, as we just talked about. And there's the alphabet soup, the ACO, the CIN, and the IPAs, right? So let's just touch upon those for a second. Any of those, belonging to any of those, can help you with health plan negotiations. You have to think about joining an organization as your backbone, as your network, as your union, so to speak. They represent you, not just in negotiations, but in how you practice. So you want like-minded, you want people who work like you, who think like you, but want or have the same values as you in taking care of patients. IPAs are, as they say, independent practice associations, independent physician associations. These are not employed, but they share infrastructure. They have single sign-on ability through contracting for professional capitation and value-based care contracts. ACOs, as we know through Medicare and now through private payers, are risk-bearing physician organizations, a parallel clinical entity. A CIN, on the other hand, is not. It's a contracting vehicle that can engage in PPO contracts for rates and value-based contracts once you're clinically integrated. Importantly, none of those are mutually exclusive. IPAs can join CINs, and ACOs can be part of CINs, and vice versa. They could be physician only, and they could be physician with systems. There are no rules necessarily. It's coming together to practice medicine in a better manner, more efficient, higher quality manner. And if you meet those criteria, you can be clinically integrated and contract as such. So all those vehicles can help you with health plan negotiations, as I said, to move the value and move upstream on that premium dollar. So what is clinical integration? Real quick. This comes out of the FTC. These are their words. 1996 was the ruling. It said an active and ongoing program to evaluate and modify practice patterns by the network's physician participants and create a high degree of interdependence and cooperation among the physicians to control costs and ensure quality. So there's a couple of key parts in that one quote: active and ongoing, right? So that's where you join CINs and they're doing reporting on you and they want your quality metrics and you think you're being needled, and it's a requirement. This is the FTC, and if you want to have negotiating leverage, you have to also play by some rules. It is just the rules. So you have to be part of a program that wants to continue to improve taking care of your patients, and there's really nothing wrong with that. And these are meant to be and are physician-led and physician-managed. How that plays out matters, and that's what you need to investigate. So how much autonomy, how much dependence. Okay, next slide, please. So as I said, clinical integration, physician-led, physician-managed, but it is a commitment, right? It's a commitment for information sharing and exchange. You have to be ready for that. It's a commitment to work together, and that allows you to have that signatory leverage in contracting. It's a commitment to adherence to quality programs and to continual improvement. It's a commitment to variation reduction and to control expenses. A commitment to using your teams, using care management, disease management, wraparound services, CBOs, the FQs, use people. We need a broader team on our side these days. And it's a commitment to remediation, to allowing for help if you're not doing well in those things. And if you can commit to those things and work together with a network of docs, physicians can be the ones who are leading the change of healthcare and how it should be organized around them. Next slide, please. So as you look at value-based care and the progression, the march towards value-based care, it's moving up that premium dollar, as I said. So as you look on the y-axis, going up that y-axis, you're taking on more financial risk. The bottom, zero part is fee-for-service. Just no risk. You just get what eat what you kill. On the x-axis is your infrastructure, right? It's your transformational work to order to handle more risk and not lose your shirt and be able to manage patients in a higher quality, more efficient manner. That requires data and infrastructure and care management support and wraparound services and lots of things, right? So that costs money. So if you move up the y-axis too fast, you take on more risk and you don't build the infrastructure, well, you're going to probably lose your shirt. If you move down the x-axis and you transform your delivery system to be highly efficient and don't take on that risk, you make the health plans a whole lot of money. So you want to stay along that 45, and they have to lever up together. So here's a way of looking at the different types of programs that have been in play and where things are heading, all the way up to provider-owned and full capitation. And the size of the circle, the size of the bubbles represent the opportunity size of that type of contracting. But with it, there's downside risk as well, obviously handled differently across different organizations. Next slide, please. So when you're thinking about sort of where your practice needs to be, where your medical group needs to be in a larger ecosystem, across a larger geography, across a regional cooperation in times like this, where some of the gloves have been taken off, allowing previously competitive entities to now help each other, capitalize each other, invest in each other, and work together towards a greater network. You can be part of that or you can be left out, right? So you need to start thinking about where you want to be and how can you best survive in that kind of consolidated market coming forward as well. Do you have the access and capacity through telehealth, through flexible sites of service if you need to see patients elsewhere? Do you have a platform for clinical integration, data sharing, and improving quality? Have you built those strategic alliances with your community and other network providers? Providers who are competitive was a great thing for health plans, but providers going forward shouldn't be the ones necessarily competing against each other. There's I guess bigger demons out there. You want to make sure you're aligning incentives, right? Fee for service just proved it broke. It won't work all the time. If you were fully capitated, by the way, you would have retained your income this whole time. That's just the way it works. Now, that doesn't mean you still need to have access to your patients and see them. You still need different care models. That's a different story. But we're talking cash flow. And I think physicians now, we've had a flavor of value-based care now for almost 2 decades. And it's been of mediocre success with mediocre effort. But what I would say is that it's been because the incentives have never been aligned, and that all physicians have been getting are more or less incremental bonuses for being well behaved. And that's not going to change a healthcare delivery system. And physicians need to seek compensation reform. You should want it that aligns your effort with what they're asking you to do in a sustainable way. What just happened is not sustainable. And keep in mind there'll be new networks out there, right? New networks are being built across FQHCs and RHCs and CHCs with your CBOs and hospital systems and community networks, because you're now sharing patients that you probably never shared before. Not a bad thing, but this is the time that, Winston Churchill, had said, paraphrasing him, never let a good crisis go to waste. And that's what's happening now. Next slide, please. So, we talked about the grants and loans being sort of the immediate. We talked about the strategy around your payer value proposition, your practice value proposition, and how can you be compensated, redeployed, or operate under a new care model, literally at the need by flicking a switch, because that's what was needed this time, and we don't know what will be needed next time. Now's a good time, if you can, if you're capitalized, if you have strength, if you can use some of those funds for practice expansion, be the consolidator, physicians can come together and be a much more dominant force. But they need to collaborate. The collaboration needs to be purposeful and want to integrate, but it needs to favor you and value you for what you're good at, and not, otherwise we're going to be swallowed up in the next round of consolidation. And again, new partnerships. So with investments, if you're going to take investments from a new partner, from a system or a hospital for telehealth, for other solutions, for other platforms, for other resources, you have to be in line and be prepared to continue those efforts towards clinical integration with them and be part of a greater network going forward. But providers are not in a weak position now. They need to start thinking of where they're going to be when this COVID crisis ends, and how they're going to continue to deliver care to their patients in any setting. And on that, next slide, I'm going to hand it back to Alan. Thank you.
It's always hard to follow Andy and Sam. Thank you so very much. Let's flip to the next slide, please. So, you know, I think Andy did a great job wrapping it up. At the end of the day, the way I think we'd ask you to think about this is, number one, there's money out there, you deserve it, you're doctors, you're running groups, you're running practices, apply now. When you apply, you have to document. Make sure you've got really clear, easy to understand documentation of your revenue losses and how you came up with that. And also, by the way, even though some of the funding applications now do not require COVID-related costs, track your COVID-related costs, because these applications that we're talking about right this minute are not the only one. And generally what we're seeing traditionally with disasters like this is you always want to track your revenue losses with clear documentation on your assumptions around why you have a revenue loss, your COVID-related costs, disaster-related costs, with clear documentation. So, you know, for instance, if you're that doctor that has a tent outside the office, that's a COVID cost. You didn't have to have that before. Anything you have to do to power that up, staff it differently, et cetera, personal protective equipment. So make sure you're tracking those things. Don't worry about whether there's a way to apply for the funding now, because we're not done with the funding. Yes, the payroll protection program and the EIDL, the SBA programs are basically gone. Hate to say it, there's news occasionally of companies giving back their money on the big side, but the bottom line is most banks aren't even taking applications. There's a huge backlog. So clearly, if your bank says you can apply, do it, but that shouldn't be where you're focusing your time right now. Again, there may be more funding. There's $75 billion, as Sam mentioned, that has not yet been allocated or hasn't been defined as terms of how it will be allocated. So if you document those revenue losses and COVID costs, and you continue to do that, of course, into May, because it's not going to be over, you'll be better prepared when a funding opportunity comes out based on what they're asking you for. And then talk to your health plans. So across the country, what we've been seeing from health plans is many of them are reaching out to their doctors, but they may not get to you. But they're willing to prepay sometimes based on historical utilization to help doctors out who aren't in capitation today. They may be willing to talk to you about capitation going forward when that wasn't necessarily on the table before. If they don't know how to capitate, they may be willing to look at things like global risk and other types of risk that are effectively capitation without necessarily having the prepay structured the same way. So important to talk to your health plan about options, how they can help you. Also, you need to talk to your hospital and health systems. As Andy said, they have a lot of options right now. They can give you money like they couldn't before. Now they're not looking for money to give away because they're looking for money for themselves. But at the same time, they know the value of their doctors. And so if you talk to them, you may find that they have programs you're not aware of. And then talk to the local IPAs and the MSOs, the practice management groups. There are many folks out there that are trying to help physicians to continue to be successful in independent practice. but helping you with practice management or billing, right, health plan contracting. So talk to those folks if they're in your community because they're eager to talk to you and they have money as well. And then finally, as Andy said, don't forget the federally qualified health centers. Don't forget to talk to them. Some of them are really looking to expand. They have money. The number of Medicaid members in the community is going to explode and commercial is going to go down. And if you're interested, if you're mission aligned with an FQHC, if they have a good culture, it might be really helpful for you. We have physicians transitioning their practices into FQHCs. You can be a contractor or an employee. So it's another option that's important to think about versus the traditional health plans and hospitals and health systems and IPAs and MSOs. And then again, you know, you got to think about your options, right? We need you. Society needs you. And so while retirement is always an option, are there ways to work with someone to transition your practice, get someone in there to take it over for you as you look to transition? You know, there's not a lot of money to buy practices the way they used to be, but sometimes they might be able to transition your practice and then help you with payments based on actually moving your patients over to attributed contracts with various folks. There are some folks out there, again, MSOs or hospitals or health plans who may want to pay you to keep your practice open. They may also want to give you money to hire someone to expand your practice. And again, we talked about capitation and different health plan contracts. So we hope this is helpful for you. We think there is a roadmap to success. We certainly know how hard it is, and I want to personally, and our team wants to thank you all for what you're doing. I think that we answered most of the questions that were submitted. I'm taking a quick look here. It looks like Sam answered the questions that were submitted in writing. So again, a reminder, you'll get a quick survey after this. We appreciate it if you can fill it out. You'll also get a PDF and a tape of the webinar, and you'll get a copy of the questions and answers documented. We wish you all the very best. Stay safe.